But this is dead complex, and this slide shows you the range of interests that surround health and wellbeing boards. I won't go into it in difficulties, but you'll see working from the outside inwards, there are national influences, there are regional influences or regulatory interests associated with this that will set the framework in which they operate. But then there are three strong influences that affect those sitting around the table, some of whom will be sitting around the table, some of whom won't. Other partnerships, very significant other partnerships, economic partnerships, partnerships around crime and community safety, crime and disorder, issues around the role of the local economic partnership and its impact on health. There's then the whole complex issue of where providers sit in relation to this. And then there are issues too about public engagement, communities, patients, patient engagement, advocacy, and all those related sort of issues. So the small or large group of people that come around the table have got some work to do to balance all these different interests. And looking down the list of attendants, I think every one of you think you might get something out of local health and wellbeing boards. You can see who's queuing up at the bus stop behind you. A little bit about commissioning and provision of services. The Prime Minister particularly and the recent report of the Future Forum have talked up considerably the issues of health and social care integration. I think the first Future Forum, my take on it would be that integration was more about integration between commissioners and providers or between acute and community services in the health service. We're seeing much more conversation about health and social care integration. Eventually, clinical commissioning groups will control 80% of the spend locally in the health service. I say eventually because I think it's quite possible that only half of clinical commissioning groups will be authorised on the 1st of April 2013. And there's a real debate about whether in fact we're creating a Stalinist health service and a devolved health and wellbeing board structure, which is a recipe for clashes, or whether in fact genuinely we will see that shift towards greater clinical engagement and commissioning. We've got the promotion of diversity through the what's now called any qualified provider rather than any willing provider. And we've also got a proposed lead role for local authorities in setting priorities for commissioning. We've argued that that should go further. We've laid amendments to the bill about local authorities signing off commissioning plans so that they demonstrate a commitment to local priorities, but at the moment that's not on the table. So there's a lot of influencing, but not necessarily teeth for health and wellbeing boards here. For those of you with a public health background, just a reminder that the three elements of public health are being distributed in different ways. Public health is not a single amorphous lump. It has three distinct strands: health protection, health improvement, and public health advice to commissioners and to the development of health services. And those three functions are being spread differently away from PCTs and strategic health authorities and some organisations at a national level to Public Health England and to local authorities. And the health improvement responsibilities and some health protection responsibilities, but particularly advice to local commissioners, is coming across to local authorities together with the Director of Public Health and their teams. There will be a ring-fenced public health budget to councils from 2013. We don't know the amount and we don't know whether the distribution yet. And there is a strong focus on outcomes, improved health and reducing health inequalities in the guidance and so on. And I won't go into details, but happy to answer questions about the vexed interest about local authorities employing directors of public health and how all that might work in practice. This ring-fence grant has got to carry quite a burden of responsibilities, and this is just a reminder of some of the things that will be statutory responsibilities transferring to local authorities under the leadership of the Director of Public Health. And there's quite a lot there, and there will be an accountability to the Secretary of State, and there'll be some of it will be very tight and some of it will be scope for local discretion. But just you'll see tucked away in that are two of the most controversial issues that certainly local governments had to tangle with: fluoridation and sexual health. You only have to look at the recent debates in Parliament about that to know that there's controversy that surrounds all of these. Some of these are much closer to what local government does already. And to set that in context, Public Health England will be largely focusing on leadership of the system as a whole, but also issues to do with health protection, health intelligence and related matters. And the NHS Commissioning Board itself, because of its responsibilities for primary care, will be commissioning screening for reasons that are very pragmatic. They'll also be doing public health of children 0 to 5. That's largely, I cynically would suggest, so that the health visitor commitment in the Conservative manifesto can be seen through at a national level. But they'll also be doing the public health of prisoners. All a bit random, you might argue, but nevertheless important. And then the final strand of my 4 points is patient and public engagement. And this has got lost again in some of the debates about this. Nothing about me without me is something that Andrew Lansley stole, I think, from other contexts and adapted for his own purposes. But there is a strong reinforcement for a more personal approach in the health service to choice, to greater public and patient engagement in needs and in assessment, but also in commissioning. And for those who've been around a long time, like I am, yet another iteration of public engagement in the health service, this time Health Watch as a new consumer champion. Health Watch is a bit like Energy Watch. I think it's probably worth describing, but but Energy Watch at least doesn't have GPs to deal with. And Health Watch has 2 strands: National Health Watch, which is going to be hosted by the Care Quality Commission as a separate committee of the Care Quality Commission, but under its wider auspices, largely, I suggest, so as not to create another Quango. And there are real issues and tensions about that relationship, which I think CQC are keen to keep an appropriate distance and balance from. And then there's Local Health Watch, which will be commissioned by local authorities, very much in the model of its predecessor, Links Local Information Networks. I don't think anybody's happy with that, to be honest, and certainly Links aren't happy with it. And I think there are, real concerns about the independence of Health Watch, about the resources available to do it, and about the massive expectations on Health Watch because it has an expanded brief that goes across into social care as well as health. It will be different from Links in that it will be salaried staff largely. In some respects, it's more like community health councils in some respects. So just some personal reflections on history then, about whether this is integration this time and what the prospects of it are. And in a lot of what I say, I'm drawing on some work that we commissioned from Professor Gerald Wistow, and his report called Integration this time is on the LGA website. And when we commissioned it, I think he and I thought we were the only people interested in it, and therefore we were writing it for each other. But over time, it has proved to be slightly more useful. There were 2 opportunities in 1948 and in 1974 to bring health and social care together formally. And on both occasions, the decision was taken to keep them as separate systems. In 1948, that led to a free NHS and essentially an assessed means-tested charge for social care. And there were similar opportunities in 1974 when functions were transferred, health functions that local authority was responsible for, transferred into the NHS to deal with it then. So all this talk about Berlin walls, all this talk about how health and social care really ought to work more closely together is quite tough when they were actually designed to operate as parallel systems and not as integrated systems. And they've been built up independently, they're governed independently, and to be honest, they're built around the needs of providers rather than the needs of end users, particularly the NHS. And it's a real exam question about whether the new NHS really is designed in the interests of patients. There's a shift towards clinicians and their role as advocates for patients, but is it really a patient-centred organisation? But then since 1962 onwards, there's been a plethora of attempts to bring health and social care together through committees, plans, and some joint pooled budgets and I've listed some of them here. Health and wellbeing plans date back to 1962, which has a slight sort of echo of today. We've had joint consultative committees, joint care planning teams, health action zones, health development plans. We had health and social care trusts. And then around the edges of this, drug and alcohol action teams, community safety partnerships have an interest in some of these issues, and so on. And then we had the big idea that actually all of this could be dealt with through a local strategic partnership locally. And I'll say a bit later on about where those things have worked, what the characteristics were of success for those. So on the face of it, this could be just another one of those. But what are the prospects really for this making a difference this time round? To continue my update or finish my update on the bill, this is the current timetable. By the end of 2011-12, the shadow, by the end of 2011, beginning of 2012, the shadow National Health Service Commissioning Board will be in place. It has had its chief executive for a while. The arrangements being put in place to create it as an entity. This spring, Public Health England will be set up in shadow form, and we're expecting at the end of this month or early February that local authorities will get their allocation of public health funding. It's anticipated that by April, local authorities and PCTs will have agreed plans for the transfer of public health functions to local authorities, and that those functions will be delegated by October in most places and will transfer completely by April 13. By March 2013, PCTs will have gone, and we anticipate most clinical commissioning groups will be authorised. Commentators suggest maybe a lot fewer than that. But not expected in the original architecture, the clusters of PCTs look like they've got quite a long shelf life, and commissioning support organisations now coming on the scene as significant support to CCGs. And health and wellbeing boards become a statutory responsibility of local authorities by April 2013. I should stress that they are committees of the local authority in that sense, so they're different from some of the things we've had before in that they are part of the formal constitutional bits of the local authority.